All right. So infectious keratitis, and some would argue that all infectious keratitis in patients with Boston kereprostheses is complicated because often it is difficult to obtain a culture and difficult to manage because many times the infection, I think, forms a biofilm on the optic of the kereprosthesis. By way of disclosure, I have no financial interest relevant to what I'll discuss during this presentation. So we published a paper about now 8 years ago in ophthalmology regarding microbial keratitis in the Boston K-Pro patients. And one thing we looked at was whether the incidence of infectious keratitis was higher in eyes with history of cicatrizing conjunctivitis as compared to those without. And we did not see a significant difference in the incidence, although others like Ed Holland have reported a difference. We thought maybe the failure to identify a difference is because we didn't have a large number of cases of infectious keratitis in this series. So we decided it makes sense to go ahead and collect a larger number of cases with longer follow-up to try to determine the incidence of infectious keratitis following Boston K-Pro implantation, the risk factors, as well as how these patients do after treatment to try to develop some evidence-based guidelines for management of infectious keratitis following K-Pro implantation. So this was a retrospective consecutive case series of K-Pro procedures performed, as you see on the slide, during about a 15-year period. These are cases that were identified by Mona Harishi-Dagar at University of Montreal and myself. You'll notice that the post-operative antimicrobial regimen differed a bit between Los Angeles and Montreal. In Los Angeles, I typically use a fourth-generation fluoroquinolone 4 times a day indefinitely. I used to use vancomycin post-op, but stopped doing that about 8 years ago. In Montreal, a fourth-generation fluoroquinolone is used 4 times daily after surgery, but it is tapered down to 1 or 2 times daily and then continued indefinitely. The post-operative regimen at both University of Montreal and UCLA did not employ the use of topical antifungals. Topical steroids were used, but then were tapered down to 1 or 2 times daily. And in fact, usually I'll discontinue unless there's some reason to continue a steroid, such as a history of uveitis. Therapeutic soft contact lenses were placed after surgery to facilitate maintaining intact epithelium in patients who had, let's say, limbal stem cell deficiency. In some patients who were more comfortable with a contact lens, we kept one on, or in some patients who felt that their vision was better, we maintained them in a contact lens. But unless they had one of these indications for long-term wear of a contact lens, we did not continue it in majority of patients. And when a patient was wearing a contact lens, it was exchanged usually every month, sometimes as infrequently as every 3 months. So in this series, we examined 349 kereprosthesis procedures performed in, as you see on the slide, almost 300 eyes of 268 patients. The mean age was 63, and the duration of follow-up in this series was a little over 4 years. So if you look at the total number of eyes that we've monitored and over the duration of follow-up, we're looking at over 1,500 years of cumulative follow-up. So I think with that amount of data, we can actually come to some conclusions regarding, again, incidence and management and outcomes. So as far as the results, compared to the Montreal series, the UCLA series had a significantly higher proportion of eyes with graft failure as the indication for the kereprosthesis. Also, compared to Montreal series, the UCLA series had a significantly higher proportion of eyes with prior K-Pro implantation, as you see here on the slide, 21% versus 10%. However, the Montreal series had a significantly higher percentage of eyes with aniridia as the indication for K-Pro implantation as compared to the series at UCLA. So there were some differences between these series, but in both, the most common indication was graft failure, and that's true for really any series of kereprostheses. We identified 57 cases of presumed infectious keratitis after 53 procedures in 50 eyes of 49 patients. So you say, what percentage of eyes develop infectious keratitis? Well, in this series, it was around 17%. 4 cases were identified of recurrent keratitis in the same donor cornea, and there were 3 cases of recurrent keratitis in different donors' corneas in the same eye. So somebody have a kereprosthesis, they get an infection, cornea melt, we take out the Kepro, put in another kereprosthesis with a new donor cornea, then it gets an infectious keratitis. And there was 1 case, as you note on the slide, of a patient, unfortunately, who developed infectious keratitis in both eyes. The annual incidence of infectious keratitis after Boston Kepro implantation in this series was 0.035 cases per year. The annual incidence of culture positive bacterial keratitis, as you see, was about 3 times as high as the annual incidence of culture positive fungal keratitis. So the annual incidence of presumed infectious keratitis of 0.035 cases per year corresponded to development of 1 case of infectious keratitis per about 29 years of follow-up. The incidence of bacterial keratitis, 0.014 per year, corresponded to 1 case for every 71 years of follow-up, and that was significantly higher than the incidence after fungal keratitis, which is 0.004 per year, corresponding to 1 case of fungal keratitis for every 250 years of follow-up. When the incidence of presumed and culture-proven infectious keratitis in the UCLA series was evaluated, you see it's 0.45. It's significantly higher than that in the Montreal series. There was, however, no difference in the incidence of bacterial or fungal keratitis between the UCLA or Montreal series when those were evaluated separately. As expected, bacterial keratitis was more common than fungal keratitis at both centers. Obviously, this is how North America differs from India, with a significant difference in the Montreal series, but not in the UCLA series. The mean time to development of infectious keratitis, as you note, was about 20 months. So you say, when does it usually develop? Well, as you see, it's a wide range, but typically you're looking at between 1 and 2 years after surgery. You'll note also on the slide that it was significantly shorter, the time to infection in the UCLA series as compared to the Montreal series. So mean time to infectious keratitis, as you note, just under 2 years. Bacterial keratitis appearing earlier after surgery as compared to fungal keratitis. In regards to bacterial keratitis, really no significant difference between the time to diagnosis at UCLA versus Montreal. Looking here at the annual incidence of infectious keratitis, in the blue line, we have the number of cases per year out to 6 years after surgery. In the red line is the number of eyes reaching each time point, and that gives us, in the green line, the incidence. And again, you'll note here that the incidence is the highest in the first 2 years after surgery. So how does infectious keratitis present following Kereprosthesis implantation? Well, usually what you'll note is an infiltrate underneath the edge of the front plate. And this is sort of a classic appearance of infectious keratitis in a Kepro patient. It's a way it presents in about 3/4 of patients. In almost 2/3, the donor cornea peripheral to the front plate, as you see I'm highlighting here with the arrow, is also involved. And so that allows you to collect a culture to identify what the organism is. But in a certain percentage of patients, in this series about 14%, the infiltrate's confined to underneath the edge of the front plate, as you can see here in this image, which makes it impossible to collect a culture. So bacterial and fungal cultures were obtained in 47 of the 57 presumed cases of infectious keratitis. 22 of the 47 bacterial cultures were positive, and 6 of the 47 fungal cultures were positive. So that gives us a bacterial to fungal ratio of about 3-to-1 in Los Angeles and about 7-to-1 in Montreal. And that may well be, of course, because of the different climates in the 2 cities. So if you develop a bacterial keratitis after Kepro implantation, at least in North America, what are the most common organisms? Well, in almost all cases, 21 of the 22 bacterial isolates, it's staph or strep. So if you're going to be prophylaxing in your Kepro population, at least again in North America, against bacterial keratitis, those are the organisms you want to be concerned with. So something that has good gram-positive coverage is most important. We next looked at demographic and surgical risk factors for infectious keratitis. The first risk factor is being in my practice. We see a higher incidence of infectious keratitis at UCLA as compared to Montreal. We also now, with a larger number of patients and longer follow-up, do see a higher risk of infectious keratitis in patients with a history of cicatrizing disease, as you note here, as compared to those without cicatrizing conjunctivitis. Again, this was something that we did not find to be a significant difference in our initial study. There were no significant differences in the incidence of infectious keratitis for other demographic factors that we looked at, such as history of glaucoma, prior glaucoma surgery, the optic type, et cetera. But we did notice, interestingly, a borderline significant association with a titanium backplate as compared to the PMMA backplate. I honestly don't know what that association would be, but this is something that we observed. So in multivariate analysis, the only significant risk factor for the development of infectious keratitis we looked at already was univariate analyses. In multivariate analysis, the only one that remained significant was cicatrizing disease. Here we're looking on the y-axis, the cumulative proportion of infectious keratitis. In the red line, those with cicatrizing conjunctivitis. The blue line, those without. And we see that higher rate in those with cicatrizing conjunctivitis. As I mentioned, we saw an association with univariate analysis of infectious keratitis with titanium backplate, but then did not remain significant in the multivariate analysis. So we next examined post-operative risk factors for infectious keratitis. The development of a persistent epithelial defect was associated with increased risk of presumed infectious keratitis, as we can see on the slide. If we look at all cases of keratitis, as well as those were culture positive for bacteria or fungi. As we see here, also, the use of topical steroid did not increase the risk of infectious keratitis, interestingly. In fact, when we looked at the duration of topical steroid use, we noted that prolonged use of topical steroid was associated with significantly decreased risk of infectious keratitis overall, as you note here, as well as decreased risk of both bacterial keratitis and fungal keratitis when analyzed separately. Topical vancomycin use, as I mentioned, used in my practice until about 8 years ago, was not associated with a significant decrease in the incidence of bacterial keratitis, interestingly. However, it was associated with a significantly increased risk, when you looked at its hazard ratio, of fungal keratitis. And this is something I think that the group in Boston has also reported. However, we need to interpret this with caution, because if you note here, there's only 2 cases of fungal keratitis that occurred while patients were on topical vancomycin. And these occurred, like I mentioned, in the first year or so after surgery, which is when I used the vancomycin, which is also when we know the rate of infectious keratitis is the highest. We looked at contact lens wear also and determined whether that was associated with an alteration in the risk of infectious keratitis. And we found that the was not associated with an increased risk or decreased risk of infectious keratitis overall, or bacterial and fungal keratitis when evaluated separately. However, when the duration of contact lens wear was evaluated using a hazard ratio, prolonged use was associated with a significantly decreased risk of infectious keratitis overall. Now, how do we manage these patients and how do they do? Well, of the 53 cases with available outcome data, 34 of them were successfully managed with medical treatment. So overall, about 2/3 of cases of infectious keratitis after Kereprosthesis implantation can be managed medically. For the 29 cases which the date of the resolution of infectious keratitis is known, the mean time to resolution was about 3 months. Of the 30 cases of medically managed infectious keratitis for which the visual outcomes are known, 9 eyes, around 30%, lost 2 or more lines of corrected distance visual acuity. So 36% of eyes required surgical intervention. Replacement of the Kepro with a PK was required in about 21% of eyes, as we see here. Replacement with another Kereprosthesis performed in about 11% of eyes, and unfortunately about 4% required evisceration. The decision as to whether to remove the Kepro and put in another Kepro or put in a PK depend on a number of different factors, including the visual potential, whether we thought the eye still had an intraocular infection that was active, etc. So infectious keratitis was associated with significantly increased risk of Kpro explantation, as you can see here on this Kaplan-Meier survival curve. The eyes that developed infectious keratitis, we're looking at the retention in these eyes in the red line, the blue line, those that did not develop infectious keratitis. There was no significant difference in the percentage of culture-positive bacterial and fungal keratitis cases that required surgical management. So what about the complications that developed after development of infectious keratitis? Well, infectious keratitis was associated with significantly increased incidence of several complications compared to eyes that didn't develop infectious keratitis, including, as you see on the slide here, endophthalmitis, idiopathic vitritis, corneal stromal necrosis, retroprosthetic membrane formation, retinal detachment, hypotony, and cystoid macular edema. So to put our findings in perspective, we report an incidence rate of infectious keratitis after Kpro implantation of about 0.35 per year, which is in the reported range of between 0.034 and 0.073 that have been reported in prior studies. What's interesting, even though in this series we reported a higher percentage of eyes that developed infectious keratitis, 19%, as compared to our prior study looking at the rate at UCLA, when we looked at it as far as an incidence rate, it actually went down. And this is because we have longer follow-up for many of these eyes, and knowing that the rate of infectious keratitis is highest in the first 2 years, with a longer follow-up, the overall incidence decreased. So, in conclusion, infectious keratitis remains one of the most common complications after Kpro implantation, developing in about 17% of eyes, corresponding to annual incidence of about 0.035 per eye year. Risk factors, well, we're looking at indications, cicatrizing conjunctivitis. We're looking at post-op complications, persistent epithelial defect formation. Organisms, bacterial keratitis is almost exclusively caused by staph and strep. Again, this is in North America, and it is more common than fungal keratitis, which is most commonly associated with Candida species. As far as treatment, failure of medical therapy requires Kpro removal on about 1/3 of cases. In regards to outcomes, infectious keratitis is associated with increased incidence of other post-op complications, as we saw on that prior slide. So the significantly increased risk of Kpro retention failure and the multiple complications associated with infectious keratitis, I think really underscore the importance of prevention of infectious keratitis in our Kpro population through the use of appropriate antimicrobial prophylaxis, aggressive management of predisposing factors like persistent corneal epithelial defect formation, as well as prompt diagnosis and treatment in cases which you suspect in early infectious keratitis. I want to thank the collaborators at the Stein Institute, University of Montreal, and also want to thank you all very much for your attention.